Welcome back. Today we're going to continue our study of the endocrine system by looking at the endocrine function of the pancreas. It's a very large organ we've already looked at in its digestive form, or the exocrine function. And today we're going to look at it as purely an organ of endocrine function, secretion of hormones into the circulation. Let's review the anatomy first, because it is a complicated anatomy. We've already looked at the ductal system because we were most interested in the secretion of enzymes into the GI tract, its connections with the liver. But here we have a totally different function that's highly dependent upon its blood supply. Remember that the pancreas nestles in the so-called C curve of the duodenum. It is very posterior. It is an entirely retroperitoneal organ. You cannot get to the pancreas when you go straight through the abdomen without moving other organs out of the way and without cutting the parietal peritoneum that overlies the back wall. Once you've done that, here's our celiac artery and this vast blood supply. Celiac artery comes off the aorta, and then it's called the celiac trunk there. It gives off some branches to the liver and to the stomach, and then it becomes the gastroduodenal artery, just changes names. And it divides, and you can almost figure these out by yourself. I think from this time of looking at all the different blood supplies, you'll notice that if you wanted to make up a name for this artery, you see it comes off on the top, so it's the superior artery of whatever it is. It goes to the pancreas and the duodenum, so it would be a pancreatico-duodenal artery. And it's behind the pancreas. This is looking through the pancreas, so it's the posterior superior pancreatico-duodenal artery. You could have made that up yourselves. Similarly, here we have the inferior pancreatico-duodenal artery because it comes up from below. And then another very important one here, the anterior inferior. See it divided from inferior to posterior and anterior. But more important than all these names is the fact that we have a loop. Again, a big network of anastomoses that helps protect the blood supply to this very, very vascular area. We then also have an inferior pancreatic artery because it doesn't go really anywhere else. And it meets a branch of the splenic artery, which is named for its end organ. Very big, very important artery. And just to remember where you are, when we looked at the adrenals, we saw the inferior phrenic artery go up and give extra blood supply to the adrenals. So this is the physical position of the pancreas, a very well-protected organ, and its very, very extensive blood supply. It's named really for its exocrine function, pancreas, all flesh, meaning its digestive abilities, and that part of the pancreas that digests food is 99% of the mass of the pancreas. What we're going to study today is really only 1% of the entire mass of the pancreas. Now, there are several million scattered structures within the pancreas called the islets of Langerhans. If you look at this next slide, this is a section of one of these islets. It is actually a globular mass, so it would be like a little tiny ball, but this is a section cut through it in one plane, so we're looking basically at the top of a hemisphere. The islets contain two very important types of cells. Pictured here are the exocrine acini, circles of exocrine glands showing the duct in the middle, and that's part of the digestive tract. Remember, that's where the pancreatic enzymes for digestion go. And if this were more complete, what you would see is thousands of more of these exocrine acini filling up the whole page, with one little islet cell for every 100 areas of the pancreas, just 1%. But let's focus down on just the islet cells now, which are inside the green. And the first cells we want to look at here are called the alpha cells. And these are pictured in light blue. They represent approximately 20% of the islet cells. Okay, you can see here roughly a fifth. What they secrete is a very important hormone, a messenger called glucagon. And guess what it acts upon? It acts upon glucose. And what glucagon does is it raises blood sugar to maintain normal levels. It will not, in normal circumstances, raise blood sugar much above normal levels. Our body likes to have about 80 to 100 milligrams in every 100 cc's of blood, which is the number you get when you measure blood glucose. And we don't like it to go too high for reasons I'll talk about later. We certainly don't want the blood level to go low. Not so much for the rest of the body, but because of the brain. Remember, the brain is too metabolic to have any room for storage, so it has zero stores of glucose. The brain gets its glucose on an ongoing basis from its blood supply. Any blocking of the blood supply or dropping of the level of glucose is going to affect the brain in minutes, if not seconds, very, very quickly. Now, the glucagon secretion into the bloodstream, and if you look here, notice there's lots of capillaries on this slide. So these cells are all going to be very close to capillaries, and the glucagon can get in there by diffusion. The glucagon is responding to low levels of sugar in the blood, or lowered levels. It is a direct response to that chemical happening. There are sensors throughout our system that measure glucose levels in the blood. These are called chemoreceptors. And anytime there's a deflection downward in blood levels below normal, glucagon is signaled to be released and brought back up into the system. Now, the way it does that, it stimulates hepatocytes. Hepatocytes are the cells in the liver that we've talked about, and it acts upon them to convert glycogen. Glyco refers to sugar, GEN is the genesis, so glycogen is a big complex molecule that has glucose in it. And that molecule is broken down in a process called glycogenolysis, lysis at the end, and this converts the glycogen into glucose. The hepatocytes can also convert amino acids into glucose. So as I mentioned in another earlier lecture, it can take these little building blocks of protein, which really don't look very much like glucose, and perform chemical surgery on them and turn them into sugar molecules. That's called gluconeogenesis, meaning new glucose taken from something that wasn't glucose at all, but rather a protein molecule. And then there are higher than normal levels of glucose in the serum or in the blood. And it's actually, when I talk about blood and serum, I'm talking about them interchangeably. Clearly, it's not in the red blood cells that we're interested. It's in either the plasma or the serum. But we tend to say blood sugar. We really mean serum or plasma sugar. So the higher than normal levels turn off the glucagon. There's a negative feedback mechanism going on, and we don't need any other signals in the body. The chemoreceptors are enough. That's the way the body looks at blood, by directly measuring the levels in the blood with chemoreceptors, just the way we do with a laboratory test, whether it's a dipstick or a chemical test. We look directly at the levels of sugar in the blood. We don't measure tissue levels, for example, or any other levels. This, if you stimulate the sympathetic nervous system in preparation for stress, fight, flight, and fright, this will also release glucagon. After all, what do you want to do in the stress situation? You want to give sugar to all your organs of battle, your muscles and your brain and your heart, things that allow you to do battle. And so we have here both neural and hormonal signals coming down to the pancreas. We have circulating epinephrine and norepinephrine will also stimulate glucagon release, as well as nerve endings that come down from the sympathetic nervous system directly to stimulate the pancreatic cells. That's glucagon, 20% of the entire structure of the islet cell. Everything else that we talk about here is the opposite. We have the cell called the beta cells. These are really the important cells, have been studied for a long period of time, and they're pictured here as being this tan cell comprising approximately 80% of the islet. These are very, very important, and they have been extensively studied. The beta cells secrete insulin, a word almost everybody in the world is familiar with now, and insulin lowers blood sugar. It also is in response to chemoreceptors. This time when the chemoreceptors detect too high a sugar above the baseline, then the insulin is secreted to lower it in response. Now, it's not just lowering the sugar for the sake of lowering it. There's a very good reason. And that reason is that abnormally high sugar levels have a very detrimental result in an indirect way. It's not just that it's high in the blood, which is bad enough. It's also that it's not getting into the cells where it can be used. So when the beta cells are stimulated, the insulin acts upon all the cells in the body in very specific ways. First of all, it increases the speed of diffusion into the cells. Sugar can go across the membranes from the blood into the cell in a passive way by diffusion, but they can also go actively, and insulin helps do that. It will go into all the cells of the body, but especially the skeletal muscles and the heart muscle, okay, for the restoration and recovery of those muscles so they can use the sugar. It also increases the synthesis of proteins from amino acids. That's another building block which is very, very important. And it will also increase the synthesis of fatty acids in the body, and especially as they are made in the liver, because we tend to burn fat in emergency situations when we can't get to the glucose. We have situations the same as animals have, where we need to have stores of fat. Going into hibernation, for example, for the winter, animals put away large stores of fat so that they can burn that fat over the long period when either they're asleep and they're not eating, or when food's going to be scarce. Deer, bear, the animals that live in cold climates where winter's going to be very, very harsh, use this to put fat into the stores, especially the liver, but in other tissues as well. They're going to use it later. It's very inefficient, and I'm going to talk to you about what happens when we burn fat selectively. Insulin also decreases the rate of glycogenolysis, of the liberation of glycogen into sugar, and gluconeogenesis in the liver, of making new glucose. Everything is the opposite of glucagon. You can just memorize one and you'll know what the other one does. And then lower than normal glucose level in the serum will suppress the output of insulin in a negative feedback method, just the way it did in the opposite direction for glucagon. Now, there's some things we can make use of here. It's rather interesting. Let's go to the practical, which I like to do. This is all very theoretical. There's an ion called potassium that resides primarily inside our cells. It's an intracellular ion. We have very low levels of it in our serum, maybe 4 or 5 milligrams %. Remember I said glucose is 100? And the opposite is true of sodium. Sodium is not very high inside the cell, but it may be 140, 150 milligrams % outside the cell. And it is the reversal of flow of these ions electrically which is responsible for the conduction down nerves and down muscles. We've talked about this briefly, have never really had time to get into it in detail. But it's the difference in that concentration that gives you the electronic potential, the potential energy between the two. So low-ish potassium outside the cell in the serum and also in the tissues competes with or is placed against the high levels inside the cell, and it's that exchange that allows us to have conduction. There are cases when the potassium can get too high in the serum. If, for example, you have kidney failure, we get rid of potassium through our kidneys. Excess potassium is very, very dangerous. Because if you decrease the difference between the outside and the inside of the cell by raising serum potassium, you can stop nerve conduction, you can stop the heart. The first thing that will happen with the heart is the heart stops. If you want to stop a heart on an operating table, one of the things you can do is give potassium, and you can restart it later. Lethal injection, the final stopping the heart, is usually done with a potassium. We give patients potassium at a slow rate to replace it, but if you shove it in one big dose, it will stop the heart like that. We have a problem then in these patients who can't get rid of their potassium if we see potassium rising quickly. Let's say for kidney failure or for other processes that can happen in the body, too many to go into now. Just know that it's dangerous and it's emergency. This emergency happens very quickly. One of the things we can do is that sugar going into the cells happens to grab potassium on the way. And we get a patient in the emergency room whose serum potassium is dangerously high, maybe double normal. One of the things we can do is give that patient an IV in a big syringe of 50% glucose. Usual IV has 5%, so 50% is very concentrated. And at the same time, give insulin. We shove the glucose in, we give insulin. Insulin drops the potassium by driving the sugar into the cells in seconds. This is not a long period of time. And then it will stay there for a while, and maybe we can make adjustments for the patient, or we can do it again. Now, you might say, well, why not just give the insulin, drive everything in the cells? If we did that, we would drop the serum glucose. And that would be even worse than what we already had. The brain would be affected, patient would lose consciousness, there'd be shock. We'd have a very serious situation. So we combine the two together. We drive the insulin into the the glucose into the cell by using the insulin, drop the potassium. Nice use of physiology to correct an abnormal situation. It used to be that we got insulin from pig pancreases. That supply was always a bit of a problem. Today we use genetically engineered insulin, human insulin, so that you don't become allergic to it. And we do this again with bacterial factories using genes taken from the pancreas, and they just turn out insulin, pure, 100% perfect insulin of the human form in as much as we need. Other factors which affect insulin release include parasympathetic innervation to the islet cells, because this would stimulate insulin for rest and recovery, and glucagon itself causes insulin release to balance the effect of the insulin. So we have very delicate negative feedback loops, and we try to keep that glucose in a very, very narrow range. There is another peptide which comes from the enteroendocrine cells, which we've studied already, and it's called gastric inhibitory peptide. And that also happens to respond to glucose in the lumen of the gut. And that has the same effect. It's trying to get ready to bring down the glucose. Amino acids also affect insulin release because they're getting ready to be made into glucose, and insulin is therefore on hand to try to suppress that. Those are the beta cells. Now the next cell, there's another one in here that's hiding called the delta cells. These big purple cells here, very few of those, less than 1% are delta cells. They secrete a drug called somatostatin. It's a growth hormone, inhibiting hormone. Remember, we had somatotropin coming down from the pituitary axis and studying the adrenals. Somato means body. Tropin means it stimulates the body cells to grow. Here's somatostatin. It inhibits growth hormone, and that comes from the pancreas. The same drug is the one that is also delivered from the hypothalamus. It's a second reservoir of it. And this hormone inhibits insulin release. It slows absorption of nutrients and basically takes all the pressures to slow them down. There are also insulin-like growth factors that are found in many tissues of the body. They have the shape and the look of insulin and a molecular structure, and they are also hormones. They are involved in abnormal and normal growth, and they have been used synthetically to help people who are not growing fast enough or who don't have normal growth hormone to achieve normal size. But again, you can't fool Mother Nature. This is also used by cancer cells. In almost all cancers, rely on growth hormone. Giving excess amounts might have a danger attached to it. And finally, there are F cells here scattered. Here's these little green guys. They look just like the other ones. And they secrete something called pancreatic polypeptide, which is a small group of amino acids, and it inhibits the release of somatostatin. So here you have this little islet that has lots of negative feedback mechanisms. Everything seems to have a counterpart within the islet cell. Which brings us to the subject of diabetes mellitus, one of the most important diseases, accounting for perhaps the fourth most common cause of death in America. Diabetes mellitus means literally copious urine. That's the diabetes. Mellitus means honey-like or sweet. So this is sweet, copious urine. This was discovered many, many years ago, more than a couple of centuries, when doctors saw patients with a certain complex of symptoms, and they noted that the urine had sugar in it. How did they know this? Well, they tasted it. That was the best lab test they had. You could dip your finger in it and actually taste the urine, and that's how it got its name. Patient came in with excessive urination, and the urine was sweet. And we're very interested in the history of medicine in medical school, so our first day in the lab studying the urine, we all sat there with our own bottle of urine, and the teacher said to all of us, you're going to do just what the old doctors do. We'll see who has sweet urine. And he stuck his finger in his urine glass, licked the finger, and said, everybody please go ahead. And we all stuck our fingers in, tasted our urine, made terrible faces, everybody groaned and complained. He said, no, you've missed the point. I'm training you to be observant. I stuck my index finger in, but I tasted my middle finger, and you've all missed the point. So he was right. None of us got it. But in any case, that was how this all started. That's why it's called diabetes mellitus. Now, it's characterized by what we call the three polys. If you go to the next slide, the three polys are what are called polyuria, polydipsia, and polyphagia. And all the polys are represented in the different kinds of diabetes. Polyuria is the diabetes part of it, the copious amounts of urine production. These patients are urinating all day long. Polydipsia is increased frequency of drinking because these people lose so much water, they're always thirsty. And often this is what brings them to the attention of the doctor. They don't know they have diabetes. They say, Doc, I don't know what's going on. I'm just peeing all day and drinking all day, and I just can't seem to satisfy my thirst. And that's because they're losing sugar and water in the urine. Finally, there's polyphagia, the third of the three polys, which is lots of eating. Large amounts of eating, because these patients are actually starving. They are internally starving their cells because they're not getting the sugar into the cells. They have high levels of sugar, but they're not getting to where it can be. So metabolically, they're starving. Now, there's two kinds of diabetes, and remember that these polys, the three polys, occur in all of them. The first type is called type 1, and this is insulin-dependent diabetes, sometimes called IDDM, insulin-dependent diabetes mellitus, and it's not a big percent of the total number. It's about 10, maybe 20% of all the cases in the world. In this type, there is an absolute deficiency in the quantity of the insulin available. So the beta cells are not making enough insulin. Therefore, there's not much you can do for these patients other than give them insulin. It's also known as juvenile onset diabetes because it often occurs in childhood for the first time. It tends to be very, very what we call brittle. It's hard to manage these patients. Their insulin requirements and their dietary requirements are all over the map. They are not like the other diabetes we'll talk about, where you can get a person into a set diet and a set amount of whatever the therapy may be, and they're okay. These are very brittle diabetics, very, very hard to manage. It's probably an autoimmune disease. We've talked about that before. The body becomes allergic to its own beta cells and tries to destroy them. And that's why there's just not enough insulin. Because the patient doesn't have enough to make, the beta cells are the ones being injured. So this patient is in a chronic state of starvation, unable to use nutrients without injections of insulin. They cannot be controlled with diet or exercise. Most patients with the other type of diabetes we're going to talk about can be controlled with diet and exercise, but this patient cannot. The cells try to use fatty acids to produce energy. We mentioned this as the emergency. So the cells of the body have no place else to go. They need to get energy somehow. And what it can do is it can use the fat since it can't use the glucose. Now, what happens to that patient, when you burn glucose, you get a very clean burn. The products are carbon dioxide and water and not much else. When you burn fats, you get products called ketones. We've talked about that earlier in nutrition. And ketones are an organic product of combustion that are very, very acidic. So these patients have high glucose, high levels of insulin, but it's not working, and they therefore burn the fat, and they burn this fat producing ketones, and you can smell this on the patient's breath. One of the ketones is acetone. That's the simplest ketone in the organic world. You can smell acetone on their breath, and they're very acidotic. Their blood pH falls, and as we know, precipitously falling pH is very, very dangerous. It affects all the systems in the body. So this really has to be corrected. It's known as ketoacidosis, and severe ketoacidosis is rapidly fatal. Now, treatment is easy. We give these patients insulin when we make the diagnosis. And in fact, again, let's just pull back for a second and talk about the physiology. There is a very popular diet, which is the low or no carbohydrate diet. The way that works is it makes you a diabetic, because diabetics selectively burn fat. And that's what a dieter wants to do, selectively burn fat, leave the muscle alone. Now, there's something in the body called the Krebs cycle. The Krebs cycle is the cycle in which glucose is burned and in which we get energy most of the time. It requires a primer of 100 grams of glucose to get that fire going. It's really the match that you light to light the kindling, to light the logs. The 100 grams of glucose is the match. Without the match, there's no fire. So what this diet does is it restricts the glucose intake or carbohydrates to below 100 grams, and that fire can't get started. Then the patient is made diabetic. The patient goes into ketoacidosis, maybe a mild form of it, and they actually think about the success of their dieting by whether their breath smells from acetone. Many of them buy dipsticks, chemical dipsticks, that are available to diabetics to check their urine, and if they have acetone in the urine, they go, yes, I'm really doing a good job on the diet. But this can get out of hand because you're mimicking a disease process, and there are times when this kind of dieting is dangerous, and in fact, there are times when it is self-defeating, because if you've taken on all this protein and fat, which is so delicious, and ignoring the intake, because you know it's going to be burned up, if you go over your 100 grams of carbohydrate, then you can light the Krebs cycle, and then you can start converting everything back into fat again. So there's a lot of things wrong with this diet. A lot of people have been very successful with it, but again, you're interfering with Mother Nature in a way that may be very dangerous. And there have been deaths on this diet. There have been people who've gotten very sick. Let's come back to some of the things that diabetes can do. The patients who have diabetes have a lot of problems. And we call this a protein disease, not protein, but protein, meaning widespread. Diabetes affects every system in the body. And by just regulating blood sugar, we're not always sure that that regulation does prevent some of the other complications. It's still hotly debated. The physical defects related to high blood lipids. Remember, these patients also have fat circulating, causes blood vessel damage, atherosclerosis. So these patients have a very high incidence of strokes and heart attacks and kidney failure because the blood vessels to the kidneys are affected. So we know that the death in diabetics is often not from blood sugar, but from stroke, heart attack, kidney failure. They also have increased rates of infection because their blood contains a lot of sugar, and sugar is a very good way to grow bacteria. When we grow bacteria, we usually give them lots of sugar. And also they have what's called peripheral vascular disease. The blood vessels going to their legs, for example, are often affected. Very high rate of amputations in these patients. And it's small vessel disease. It's down near the small arterioles and capillaries, so that doing bypasses on big vessels doesn't help these patients at all. They also have two kinds of eye problems. They have cataracts, which we remember are opacities in the lens. But that's one that's absolutely related to high blood sugar, more than anything else. The sugar in the fluid that diffuses into the lens, remember the lens has no blood supply, but it diffuses in the liquid, gets into the lens and unites with the proteins of the lens, forming a glycoprotein which happen to be opaque. And little by little the lens clouds over and these patients can't see. They have to have their lens removed. The other thing they get is diabetic retinopathy, retinal problems which are again vascular. They get hemorrhages and scarring in their retina and they can't see. So those are the main serious complications. Obviously, this is something that has to be very carefully monitored, diagnosed, and treated. We say we can treat diabetes, and as with many other diseases, it is not curable. There is no cure for diabetes right now. There is treatment. We treat them with insulin replacement. Standard treatment for a type 1 diabetic is insulin injections daily. And there are experimental treatments that include pancreatic transplants or even selected islet cell transplants. They've experimented with putting islet cells into semi-permeable tubes that keep them away from the blood supply and the antibodies that might reject them, but allow diffusion into the bloodstream of the insulin itself. We're now focusing a lot of the research on stem cells, seeing if we can tell the stem cell of that patient or others to become an islet cell, a beta cell, and maybe implant those somewhere where they can work with the negative feedback loops that are already there. So lots and lots of research devoted to this worldwide enormous problem, one that is both physically, emotionally very, very bad, as well as economically very bad because it uses a lot of resources. Type 2 diabetes is non-insulin dependent diabetes mellitus, NIDDM, and it's also known as maturity onset diabetes. This one accounts for about 90% of the cases, more or less. These patients tend to be more than 40 years old. Many are obese. It's a much milder form than type 1, much less brittle, and much easier to control. Many patients, the majority of them, already have normal insulin levels. So it's not a major defect in the beta cell. What it is their target cells are less sensitive to the action of the insulin. So if we can do things to help the situation, we might be able to intervene without actually having to give insulin. Still includes the same 3 polys because the symptoms are from high blood sugar, among others. The treatment in these patients almost always is first weight loss, because obesity upsets this balance and may use up too much of the insulin in this obese body. That's the first thing that we do. Second is exercise. There's a very beneficial effect of sustained daily exercise. So weight loss and exercise together will make most of these patients lead a normal life with no other treatment. Then you have another portion that don't respond to exercise and weight loss or won't, which is called patient compliance. And those patients can be put on insulin stimulating drugs, which just go to the pancreas and whip the beta cells. Since the beta cells have insulin, we just may need more to get out into the circulation to whip the cells of the target organs that are resistant. So I would say in that group between diet, exercise, and then a group that needs insulin stimulating drugs, you are going to probably take care of most of the diabetics. And then finally, even in type 2, there's a few patients that still need insulin injection. There are different ways of giving insulin now. Most patients take a shot into the thigh or somewhere else 2 or 3 times a day, given both long and short-term acting insulin. They have very quick ability. They don't have to taste their urine. They can stick their fingertip, get a micro drop of blood on a piece of paper or a machine, get an immediate reading, and know just where they are. Elliot Jocelyn, very famous researcher and physician from Boston at the Joslin, then now the Joslin Clinic, was one of the first people to really educate the patients. They all had to go to school as inpatients, learn all about diabetes. Most of his patients knew more about diabetes than most physicians, and they were able to care for themselves in meticulous fashion, giving the patient the power over this disease. And he did some of the earliest and most conclusive research on diabetes. Other patients now have insulin pumps, which are worn on the outside, filled with insulin, but go through a catheter to the inside of the body where they measure blood glucose and respond with a microcomputer to the amount and dose needed minute by minute. Now that has the downside of having to wear an appliance that goes through the skin, has to be meticulously cared for so it doesn't become infected. But that's another way to handle this. It's really patient choice most of the time. And finally, there's gestational diabetes, which results from the patient having an elevated blood glucose during pregnancy. The causes are similar to those for type 2 diabetes, and the most important factor here is it affects the fetus. The fetus is usually born very large in weight and size, way over the top of the normal range, like 12, 13 pounds sometimes, but it's not good weight. It's not muscle, bone, and protein. It's edema. It's the retention of fluid in this baby. And these are a very special group of patients that have to be cared for immediately after birth. Let's look at the clinical picture of diabetes, because we have 2 kinds of out-of-control patients. We have the patient whose blood sugar may be too high, because they haven't gotten enough insulin, or they may overtreat, and we may have the patient whose blood sugar is too low, and we have to treat them obviously differently. And if you get out of the range of normal everyday living with some kind of stress, and that stress can be infection, it can be trauma, any stress tends to throw this whole balance out of whack for these patients far more than it does for the ordinary person who does not have diabetes. So these patients come into the emergency room with a very interesting pattern. Let's talk about the extreme patient, not somebody who's just borderline. Patient will often come in with lethargy or coma. They may be totally unconscious, or confusion. And when you question that patient, if they're even awake at all, you really can't find out much from them. They may not remember when they took their insulin, how much they ate, what their dose was, although today many of them carry a card or a bracelet to let you know this. Very important. But let's go back to years past. We would get a patient in the emergency room who was in coma, and we knew they were diabetic from whoever brought them in. Or maybe you'd see all the needle marks on the thigh, or they may have had an empty syringe with insulin in their pocketbook or pocket. So the patient's there in coma. In those days, we didn't have a dipstick. We didn't have a rapid test. We have to draw blood, send it up to the lab, which took time just walking the blood away, and then we'd have to wait till the tests were run. The answer came back. Meanwhile, this patient's brain is being damaged. They're in coma. We'd want to do something. What we did was, surprisingly, we gave them all sugar. We'd get that 50 cc syringe out in those days and just ram in a lot of sugar. Now, the one who was in insulin coma from too much insulin, too little sugar, maybe they forgot to eat breakfast and lunch and took their insulin anyway, that patient would sit up and go, hey, what happened? Where am I? What's going on? Because they'd immediately get a rush of sugar to the brain, which would then be revived. And by the way, they might then slowly go back into confusion and lie down again. We'd have to give them more sugar till we used up all the insulin. That was almost a diagnostic tool, shoving in that sugar. The other person who's got way high levels of sugar in their blood from not taking their insulin, that patient, we're not going to do any harm to. We now have a blood sugar instead of 90 of 1,300. Shoving in 50 cc's of sugar may make it 1320. it's not going to make any difference. But what we'll know is nothing happens to the patient. They don't get better. So we'll know that patient may need some insulin. By then, the laboratory results are back, and we give that patient insulin, and they get rapidly, but not as rapidly, better than the patient who needed the sugar. Now, other things besides lethargy, confusion, the patient who is in ketoacidosis would have the acetone on their breath, so you need to smell the patient's breath and treat them accordingly. These patients also have to be differentiated from another group. We have lots of patients who come in coma today who've taken overdoses of narcotic drugs. Narcotics, heroin, morphine, lots of the drugs that are out there, the designer drugs, depress the central nervous system. They may look like a diabetic. They come in, but they don't have a history of diabetes that we can find out. And they don't have any of the equipment on them of a diabetic, but we still may not know. And one of the tests we do with those patients, we'll draw blood for a screen, send it up to the lab for a drug screen, but that takes some time. We'll give that patient Narcan while we're talking about comatose patients. And Narcan immediately reverses the effects of almost all the narcotic drugs. That patient, too, is going to come flying out of coma, sit up, but usually wild and crazy because they now have had acute narcotic withdrawal. It's as if you took someone who was trying to get off their narcotic habit and made them go cold turkey. Except instead of going cold turkey for hours or days, they now go cold turkey in seconds. And they become wild and uncontrollable and have to be restrained. And again, the Narcan will wear off a bit, and they may go down and need some more. But it makes the diagnosis, and that's the three different problems you get when you have patients in coma who haven't had head trauma. It's most often, in some cities, going to be, or some hospitals, going to be insulin problems. In other areas, you know it's going to be a narcotic problem. Brings us to some of the less common of the problems we have with the pancreas. This is an area that also can release hormones that we're not always interested in having in our system. Benign tumors in general, which we're going to talk about in the very last lecture, tend to be the ones that are capable, if they're tumors of the endocrine system, can be capable of secreting large amounts of hormones that we don't want secreted. They become autonomous. And because of their big mass, we're going to get more of that hormone into the system than we would care to have. Malignant tumors, again, we'll talk about that, because they're so bizarre and so damaged, even when they come from an endocrine organ, usually have lost the ability to secrete whatever hormone it is. So they're a problem because they tend to spread and kill, but it's these benign ones that are a problem. There's a specific tumor that's not very common, but certainly common enough for most doctors to have seen one in their career, called Zollinger-Ellison syndrome. The Zollinger-Ellison syndrome is seen in a person who has a gastrin-secreting tumor in the pancreas. This was first described by Robert Zollinger, who was professor of surgery in the Midwest, and he and another doctor got their name on it. What happens to these patients is they present as absolutely wild, uncontrolled ulcer disease. They have multiple duodenal or gastric ulcers. Nothing seems to cure them. They bleed, they obstruct, they perforate, and nothing you could do in the old days would stop their ulcer problem. And what it turned out was that when they were studied carefully and we finally got chemical analysis where we could actually measure gastrin levels, we found they had super high levels of gastrin. Remember, gastrin goes from the antrum of the stomach, circulates through the blood when the antrum is either high pH or distended, and stimulates the parietal cells to make acid. Well, now here's a tumor sitting in the body of the pancreas that is sending out this signal all the time to the parietal cells to keep making acid. And these patients were uncurable for a long time. One of the ways we tried to cure them initially, we thought, well, we'll take out the tumor, but that mortality was too high. Taking out the pancreas or part of it has a huge mortality, tremendous amount of blood loss, very difficult to do. So Dr. Zollinger and his cohort said, we'll do the other thing. We'll take out the target organ. And they underwent gastrectomy, removed all the parietal cell mass, And those tumors, as long as they were benign, were no problem. They actually left the tumor in because it wasn't causing a problem other than on the stomach. They removed the stomach. And so they just had to move the whole idea and thinking around to the target organ instead of the problem. Today we have proton pump inhibitors, as I've talked about before, that just can turn off the acid. And many of those patients, I would say more than 90%, are cured by that. The remainder may also have to have gastrectomy. That completes our look at the pancreatic cells. Next time we'll go on and complete our look at the endocrine system.